Knowledge. Okay, so our topic today for our knowledge burst is talking about differential diagnosis. What else could it be if it's not autism? But based on our last session and what we know about who was in the audience, there are a lot of you who know that your child has autism and you're wondering if there's something else in addition. So even though this is titled, what else could it be, you'll learn pretty quickly that sometimes it's both. And we'll kind of talk a lot about that. So let's do the next slide. So I'm Judy Miller, by the way. These are my disclosures. I've consulted for a few pharmaceutical companies, and I do provide legal consultation, sometimes for the government and sometimes for individuals. Okay, next. So we're going to talk about two things. There's co-occurring conditions and there's differential diagnosis. So many people might be familiar with the idea that a lot of times autism is not just autism, it's autism plus. And that is probably more often the case than not. It's probably the rare individual who has autism and has never had anything else, has never had a language disorder, has never had anxiety or something else. Those are probably more rare. And but they don't all come out at the same time, and you sort of have to keep track, you sort of have to monitor things over time. So the concepts we're talking about are, there's differential diagnosis, which is when you're trying to determine what is it. Sometimes your symptoms might overlap, but we want to figure out, like, is this really autism, or is this anxiety, for example, or is it both? And you have to figure all of those out together. So that's where you're thinking autism versus something else. And then the other scenario is when things are co-occurring. So that's when there's two or more distinct things that are happening at the same time. So that's when it's autism plus something else. And the reason this is important and kind of tricky is that there are some characteristics that are shared by multiple things. There's a lot of overlap. And sometimes if you have something like anxiety or ADHD, that might be so prominent right now and affecting things so prominently at the moment that it can sometimes be hard to see the autism that's underneath, or it can sort of mask some symptoms or mimic some symptoms of autism. So there's a lot of nuance here, but we're trying to understand that sometimes we're differentiating and sometimes we're recognizing that things are occurring at the same time, co-occurring. Next slide. Okay, so the reason for a diagnostic assessment is usually to determine if autism is present and whether the child's pattern fits with that diagnostic criteria. And even though it says whether a diagnosis of autism is present, it's really whether a diagnosis of anything is present. And each condition is going to have a pre-established set of diagnostic criteria. So that's what the assessment is going off of. And the reason that it's important is that hopefully a diagnosis is, a diagnosis is information that you can use to help yourself do better and feel better. So that's the purpose of a diagnosis. So we would hope that having a good diagnosis or an accurate diagnosis will inform what kind of treatment you do, what kind of intervention choices you make, helps you understand your loved one, and facilitates eligibility for services that you might be eligible for and that will be helpful. Next slide. Okay, so I made a list of two lists of things to think about in the autism versus and in the autism plus scenarios. So on the left-hand side are the list of things that are the most common co-occurring conditions with autism. And we're going to cover each of those in a little bit of detail. So language disorder, global developmental delay, intellectual disability, ADHD, anxiety disorders, and genetic disorders. Those are the most common things that occur with autism. And then on the right are other things that also occur sometimes, but not as often as the ones that are in the more common column. Okay, next slide. All right, so when we're trying to think about, is this autism or something else, you're always going to want to take a developmental framework. There are some things that you can see or detect at a very young age, but there are other things that you really cannot accurately detect until the child is a little bit older. And so that introduces some challenges, particularly when, as we get better and better at diagnosing lots of things early, including autism, then you may need to then do sort of a reevaluation or some sort of update later on to have a chance to look. Looks like the picture. Oh, you're right. I'm sorry about that. The slide is being a little weird. Anyway, sometimes you have to do a later evaluation to pick up the things that you weren't going to be able to tell when the child was little, but now that they're older, you have an opportunity to see if they're co-occurring. So something important to think about in this is that we use the terms delay and disorder, and they mean different things. So especially when you're young, you might be diagnosed with a delay, like a language delay or a developmental delay. And the assumption there is we don't know if that is an ongoing, if that's going to be an ongoing diagnosis, or if that is a snapshot diagnosis. Right now, there's a language delay. We think with intervention, or we don't know yet, but perhaps with intervention, that the child will be able to catch up, and then there will no longer be a language delay, and language will be within the same regular parameters that it is for any kids at the same age. So that's a delay. So the idea is a delay can go away. A disorder is not something that is going to go away. When you have an early diagnosis of a delay, you don't know yet, but some of those kids, the delay is going to go away. For some of those kids, it's going to become clear that it's more than just a delay. There's actually a disorder. And that's when we'll do different things. And that is a different kind of diagnosis than just a delay. Hopefully that makes sense. If that's confusing, put it in the chat. It's very common for a co-occurring condition to be diagnosed in autism. I think that's the word behind the picture. Sorry about that. Because autism just rarely travels alone. And the more we learn about it, the more we find co-occurring conditions. And it's just part of the picture. And it just adds to a richer understanding of the child and how we might be able to help them and help them reach their potential. Okay, next slide. So back to the list of the most common things. So I thought I'd go through each one and just kind of introduce them and tell you kind of key things to think about. If you have specific questions about a particular one, you can throw that in the chat and we can see if we can dive in deeper, because there's quite a few on this list. Okay, next slide. So most common is language disorders. And here are some of the examples that you might have seen on our report: mixed expressive receptive language disorder, articulation, speech sound disorder, fluency. When we are thinking about, is this a language disorder or is this autism, then we're going to be asking questions like, what is the social use of this child's language? So when a child has delayed language, but they are very social and they're compensating and they're really checked in with other people, and they are able to get their needs met because they're looking at people and asking with pointing and gestures, then we're going to think, okay, it's really more focused on the language. The challenge is more around language communication rather than the social use of language. So that would make me think it's more just language disorder or language delay. Some autism characteristics, like difficulty with transitions, having really strong interests, having sensory issues, or scripted language like echolalia, they are not really part of just a language disorder. So I'll talk about echolalia in a minute, and Kate Bowser can also chime in if that'd be helpful. But those autism characteristics, you just don't usually see them as just part of regular language delay or language disorder. So if they're present, then I'm going to be thinking more autism. Echolalia is in a unique spot. A little echolalia is part of typical development or non-autism development. It's very common for little kids to repeat things as they're learning to communicate. What is different in autism is that echolalia lasts for longer. It's used more frequently, And echolalia is a way you can learn language, but if you are continuing to use the exact same phrase and intonation, then it's not quite, it's not, that's more autism related. So it can still be a bridge. A lot of kids with autism, one of the steps in their language development is echolalia, and then they start to use those echoed phrases in more flexible ways, and they make their own modifications to them. But in non-autism development, echolalia would be pretty brief and would rapidly become more flexible language. Okay. Marie's got a question. At what age can you start to see the difference? Oh, I'm gonna let Kate answer that in the chat. Okay, intellectual disability. Intellectual disability is very common in autism. You'll see the third point there. At 8 and older, a child should be evaluated for intellectual disability if there's any potential question. So many of you may have received an early diagnosis of global developmental delay. That is one of the things that can be a placeholder for developmental delay when a child is younger and we don't exactly know, is this development going to catch up, or is this going to turn into, is this actually an early manifestation of a disorder? So the term global developmental delay is really only clinically appropriate until about age 5. And then it's really important to get it further assessed and determine, does the difference still exist? And if it does, then it's probably more of a disorder. In the school system, and Katie can chime in if I've got this wrong, but if your educational classification is developmental delay, you can really only use that until the child is about 7 or 8 years old. And then you need to have a different educational classification, because at that point, if you're still having struggle, there's probably a disorder in there. So at around 8 years old, you can get evaluated for intellectual disability. And in autism, about a third of the kids with autism also have intellectual disability. And then another 25% have borderline, where it's not quite low enough for an intellectual disability, but it's low average. And it's the kind of situation where the child is struggling, could be struggling in school and might be struggling academically, because things are just a little bit harder for them, but it's not so hard that it's an intellectual disability. ID testing includes 2 things, an IQ test and an adaptive test. And a clinician, an MD or a PhD, who puts it all together and says, yep, this is impairing, and there's an intellectual and adaptive impairment, and together that is an intellectual disability. It's important to know this and to know about ID, because there are different services that you can access, additional services you can access, especially when your child is an adult. But sometimes you need to get on the wait list for those, for the adult services when the child is younger. So knowing when your child is younger, knowing that they have an intellectual disability might help set the right expectations for where should we put our, what should we really think about in terms of academic placements and skills development, and are we lining ourselves up so we have the eligibility for services that will be helpful as as our child grows. Next slide. Okay, ADHD is another very common co-occurring and differential. So 30 to 80%, so that tells you we don't really know, but a lot of kids who have ADHD, who have ASD, also have ADHD. It can be really hard to diagnose before school starts, and many providers just won't even really think about it, or won't seriously consider it until at least age 4, probably more like age 6. So this is another one where if you got your diagnosis when you were really young, it might be helpful to reevaluate that, or to think about that when your child is hitting school, because it was probably too early to really know for sure. So autism supports are often helpful for kids with ADHD. And so that's a great thing. And that also can help mask things, because if you are managing your child's autism really well, you might also be managing ADHD in there and just not realize it. We've had lots of families where they, they're doing things like their child doesn't sit for dinner, so they are, wandering their child around, having a bite here, bite there, snack, making whatever you want. But the child doesn't sit for dinner, and it doesn't bother the family because they found a good way to work around it. But not being able to sit for an activity that you are interested in, because presumably you're interested in food, that is a potential sign of ADHD, that it's just hard for you to have that level of focus on one activity. All right, next slide. Anxiety disorders. Many people with autism also have anxiety. The most common are social anxiety, generalized, and the specific phobia. And sometimes it has an autism flavor. So sometimes your specific phobia might be something that very few people are afraid of, but a lot of people with autism are afraid of. So a lot of people with autism are afraid of, for example, beards, men in beards, or they're afraid of a particular toy, or they're afraid of motorized toys that seem surprising. And they might look like a child who has like a dog phobia. So you would expect, like, if you have a dog phobia, you're hiding behind mom, you're afraid when you see a dog. You might see that in autism, but the content is different. It's not about dogs, but it's about men in beards. Same phenomenon, but just a different topic because of the autism. Next slide. And then genetic disorders are common. Not everyone, not the majority. We don't have genetic diagnoses for the majority of people with autism. We might someday, but many people with autism also have a co-occurring genetic disorder. And most of the time, not everyone with that genetic disorder has autism, and not everyone with autism has that genetic disorder. So it's not a one-to-one thing. It's two things occurring at the same time. Okay, next slide. So the less common things are selective mutism. So selective mutism is when you can speak in some certain situations, but not in others. And it looks like there's some anxiety around speaking in some situations. So one of the ways that we try to tease this apart is if we have video of a kid who is talking at home and they're like very chatty and they're very interactive and they're very comfortable, and then we see them in our clinic and they are very withdrawn and very kind of like frozen almost with some sort of are not talking, and they seem very uninteractive. If we don't see that video, we might mistake that for autism and say, oh, they don't have social interest. But that video would help us really understand, oh, actually they do. There's just it only shows up in certain situations. That's when we start thinking selective mutism, and it's a really helpful differential. You can have both. You can have autism but this is a common differential. Okay, next slide. Abuse or neglect. So abuse and neglect have negative consequences on your brain and on your well-being and your development. But there is no evidence that abuse or neglect or a head injury or other kind of injury has ever caused autism. So that's an important differential. We hope that would help parents reduce one more possible sort of source of parental guilt. There is nothing that you did, even if you did a lot of not great things, which nobody's saying you did, but even very significant abuse and neglect does not cause autism. It does cause a very disrupted development, and it can have lifelong consequences for your development. There are historical examples of babies in orphanages where they really had very limited contact with other people. Their development was atypical. It's not autism. There are those terrible cases of a child was, pretty much kept in a closet till they were 12, and then they are allowed out. Their development is very disrupted. It's not autism. Okay, next slide. All right, so questions